Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health Center reporting for the week of February 1st, 2021. As health professionals rooted in Oakland serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you information you can use to make the choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Please submit your questions in the comments, by direct message, or by email to admin@rootsclinic.org. Now, we know that even though the pandemic is worldwide, the effects are very different depending on where you are. So we're here to give you up-to-date information about Alameda County and Oakland in particular. Alameda County now has over 74,000 COVID cases. The city of Oakland has over 23,000 cases. So here you can see daily case rates in Alameda County. And fortunately, as you can see, it appears that we reached our peak, and that happened in about the first week of January. And we seem to be coming down on the other side of this surge. Now, keep in mind that numbers for about the past week will continue to be updating, and so those are subject to change. As you can also see, we are still much higher than we were in the summertime surge, and certainly we do not know what is in store for us next. Typically, hospitalizations, ICU hospitalizations, and deaths trail behind cases. So no doubt that we are still seeing some of the impacts of our spike. We are now at 982 deaths from coronavirus. And while hospitalizations are coming down overall, hospitalizations in the ICU remain high, with about 100 people in the ICU with COVID-19 in Alameda County. Now, we've gotten a lot of questions about the variant and what it means and what we can expect. So we wanted to respond to some of those questions today. First thing to know is that viruses mutate. That is what they do. I've seen chatter and even gotten some questions wanting to know, does this somehow prove that COVID was made in a lab? No, it's not proved that at all. In fact, I would probably think it was more bizarre if COVID did not mutate. Basically, all viruses mutate, and this one is no exception. In fact, RNA viruses like COVID are known to replicate frequently, and with every cycle of replication, that is an opportunity for mutations to occur. As RNA viruses go, and especially with the amount of COVID infection all over the world, COVID actually mutates fairly slowly, so far at the rate of about 1 to 2 mutations per month. So on average, most of the specimens we are seeing have maybe 8 to 10 mutations compared to the original. So how does this happen? Well, mutations are basically just mistakes that happen spontaneously as the virus replicates itself. It's like you're typing out a code over and over, and sometimes you make typos. Sometimes you could switch a character for another, a substitution, or you might add something extra, an insertion, or you might miss something altogether, a deletion. And those are basically the kinds of mutations, substitutions, insertions, and deletions that happen in RNA replication. Now, COVID actually makes a protein that corrects a lot of these substitutions and deletions and insertions. So that is one of the reasons why COVID-19 mutates slowly. And we know, for example, that it mutates a lot more slowly than the flu virus. But sometimes these mistakes escape the correction process. And with millions of people being infected, there are lots of opportunities for replication and mistakes in that replication. This virus is replicating a lot. When the virus is undergoing replication and makes one of these mistakes, some of the mistakes actually make the virus more efficient at spreading. Some of the mistakes are irrelevant, but some of the mistakes make the virus more efficient. It could make the virus better at latching on to our receptors. It could make the virus better at entering our cells. And there are different pressures placed on the virus that can help create the conditions for this to happen and for these mutations to then continue to replicate. So what do I mean by pressure? This is basically what's called evolutionary pressure that creates conditions that help the virus be more successful or efficient. And there are a few ways that this happens in general with viruses, and a couple of theories with some evidence behind them about how this is happening with COVID-19 specifically. One is that mutations can actually happen inside of an individual who has a prolonged course of COVID. So, for example, in a person with a compromised immune system, let's say someone with cancer who is on chemotherapy, when they get COVID, they can end up with COVID infection for weeks, a prolonged or chronic infectious course of COVID. During that time, the virus can actually mutate in that person, and then that individual can spread it. And there are case studies of this happening with COVID 19. And this has also been reflected in our experience with other viruses where this happens, like with HIV. The other mechanism that's under investigation, I'm sorry to report, is human to animal and animal to human transmission. According to the CDC, we know that cats, dogs, ferrets, and other mammals can get COVID 19. Actually, we don't even know yet all of the animals that can get infected with COVID, but there have been reports of animals being infected with this virus all over the world, including zoo animals in many places here in the United States. There have been outbreaks at mink farms in Europe, and it does appear that the infection went from humans to minks and then back to humans. So whenever COVID jumps to an animal reservoir, it can evolve there and then jump back to humans. Another thing that can create pressure and that we need to be concerned about is the effect of treatments or medications that may be used for COVID. While we don't know the impact of this happening yet with COVID 19, it is something we need to keep an eye on, and I'll talk about that more in a bit. So, based on all the experience we have with other viruses and with other coronaviruses, I think it's important to first say that no one was surprised, or at least no one should have been surprised by variants. We fully expected to see mutations causing variants. We just never know when they might happen or how important they might be. In fact, most mutations, as I mentioned, are irrelevant. They have no impact. But with the volume of replications and mutations happening with COVID 19, something was bound to stick, and it has. I do want to point out that there was a mutation early on in the pandemic, and it was a mutation in the spike protein. It was called D614G. This mutation made SARS-CoV-2 more fit, and that variant spread quickly from Asia and then Europe and then here in the United States. And before we knew it, a variant that was actually unusual before March of 2020 was present in about 99% of the samples worldwide by the end of June 2020. It basically took over, and it has continued to be the dominant strain since then. After that, we didn't hear a lot about variants for a while until around the fall when we started to hear about variants in other parts of the world. And they began making their way to the United States in the wintertime, around the time of our surge. The most notable variants so far, the ones I'll talk about today, are ones that were first detected in the United Kingdom, South Africa, and Brazil. They all have that earlier D614G mutation and some new mutations, and they all appear to be significantly more infectious. They are more contagious. There's still a lot we don't know about the variants. What we do know so far, we know from a variety of different types of research. This includes research in the lab that's based on genetic sequencing and looking at the new variants. It's taking those variants and testing them against antibodies from the blood of people who have recovered. It's also testing against the vaccines. That's all happening in the lab. It also includes epidemiological research, which looks at how fast the infection seems to be spreading in particular areas, looking at different modeling and at contact tracing data where that information is available. Also, where possible, it is correlating the severity of disease with those found to have the variant. And all of this information is taken together to try to figure out what is going on and what it means. So I'll start with the UK variant, also called B117, which was first detected in the United Kingdom back in September 2020. It was reported in the United States at the end of December 2020, and it has now spread to over 50 countries. As I said previously, the average COVID specimen right now might have 8 to 10 mutations, where the UK variant had 23 mutations when discovered in the UK back in September. So this is a significantly greater number of mutations, which appear to be giving it an advantage in terms of spreading more quickly. There are many scientists who believe that the UK strain will be the dominant strain in the United States by March. Next is the South African variant, or B1351. It was first discovered in South Africa in October of 2020 and first reported in the US in late January 2021, and it has spread to at least 30 countries now. This variant shares mutations with the UK variant, but one unique thing about this variant is that it has 8 different mutations just on the spike protein, and we really don't like that for a couple of reasons. First is because we know that the spike protein is the part that clicks up with our receptors in our body, like a key to a lock. And some of these mutations may make it click up even better than it already does. Also, the vaccines target the spike protein, so that raises concern